Sound check, sound check for the English channel. Thank you very much. I see you are nodding, so I will be your pale shadow for the first time of the session, and hopefully you will enjoy my beautiful voice. Thank you very much.
Two.
5, 4, 3, 2, 1. Live. We can start. Hello.
We can start, colleagues.
Dear colleagues and friends, welcome to our symposia titled Targeting the Heart of Diabetes. This is a joint cardiologist and endocrinologist symposia, and the four of us will try to present you the latest data about heart failure and therapeutic effects of the latest two anti-diabetic drugs in pipeline, SGLT2 inhibitors and GLP-1 receptor agonists. I must say that I'm very proud to be accompanied during this symposia with three brilliant clinicians and the lecturers, and I think you will enjoy their presentations. Before we start, I just want to say thanks to the organizing committee for inviting us to participate Eurasian Congress of Internal Medicine. Now, I will call Professor Ana Đorđević-Dikić to deliver her presentation about diastolic heart failure, challenges of diagnosis and treatment. Ana, Zoom is yours.
Thank you, dear colleagues. Good afternoon. I'm really honored to participate in this symposium and also in your Congress, and to talk about diastolic heart failure, why it is so important. It is important because there is a high incidence of heart failure in type 2 diabetes, and it is heart failure actually is observed more frequently than other vascular events such as myocardial infarction and stroke. And in elderly patients, incidence is twofold higher compared with the patient without diabetes, and tenfold higher mortality risk. In patients with heart failure, diabetes is not only a bystander, but it is a driver of the disease. And in type 2 diabetes, heart failure with preserved ejection fraction is more common phenotype. Prevalence is rapidly increasing, mainly due to obesity epidemics. No effective therapy exists thus far. So diastolic dysfunctions start very early in the course of the disease. Again, with hyperglycemia and insulin resistance, and also mechanism such as lipotoxicity, inflammation, and oxidative stress, that they are all lead towards diastolic dysfunction and overt heart failure with preserved ejection fraction. And also at the later stages of the disease, we can find also systolic dysfunction, and the end, that of cardiovascular cause. So you can see that diastolic dysfunction can be detected actually in 75% at the beginning of the disease, at early stage in young patients. And the degree of glycemia dysregulation correlates with left ventricular diastolic dysfunction severity and increases risk of incident heart failure and cardiovascular mortality. Heart failure with preserved ejection fraction become overt later in older, obese patients and mostly in women. So what is happening with the heart during type 2 diabetes? Here in HFpEF, we have great left ventricular thickness because of pro-hypertrophic effects of insulin that directs to directly stimulate cardiomyocyte growth and act indirectly by binding to the receptor or insulin growth factor 1, who promote cardiac protein synthesis. So, unlikely to have HFpEF with reduced ejection fraction when we mainly have apoptosis and cardiac cell death and fibrosis. In HFpEF, we have hyperinsulinemia, lipotoxicity, ages, and collagen deposition. So we have microvascular disease, increased sympathetic tone with high catecholamines, and at the end, we have this concentric hypertrophy and increased left ventricular wall stress. So here you can see cardiovascular pathological process, myocyte hypertrophy and slowed early diastolic relaxation, reduced left ventricle compliance and increased stiffness, reduce left ventricular long axis systolic function, reduce left atrial reservoir and contractile function, and at the end, impaired right ventricle function. So how to diagnose this disease? Here you can see simplified diagnostic approach with symptoms and signs of heart failure and preserved ejection fraction over the 50, and objective evidence of cardiac structural and functional abnormalities. So diastolic dysfunction, elevated filling pressure, rise in natriuretic peptides. And here you can see risk factors that can support diagnosis, such as obesity, physical inactivity, arterial hypertension, atrial fibrillation, ECG abnormalities. But heart failure associations suggest PEF 1 and 2 algorithm for diagnosis HFpEF. So here we have for P initial workup, pre-test assessment with the symptoms and signs of heart failure, standard echo, natriuretic peptide, 6-minute walk test. And to support the diagnosis, we have step E, diagnostic work, where we have major and minor criteria, and all of them carry some points. So you should reach point above 5 or equal to 5 to establish your diagnosis. So let us see how it works, because you have here functional criteria, morphological criteria, and biomarkers. Just to remind you for the components of healthy diastole, left ventricle should have rapid untwisting and relaxation of this helicoid myocyte structure, and should be highly compliant and fully relaxed and with compliant pericardium. So the filling should be fast, and also should have effective atrial contraction. What is happening in the diastolic dysfunction? We have elevated filling pressure. So you can see it from the filling of the left ventricle that this spontaneous filling at the first phase is increased. And this is E wave. And we should also measure E prime wave, that is actually measurement of how ventricle relaxed. What is the velocity of this relaxation? So velocity should be for mitral annulus more than 7 centimeters per second. But when you have HFpEF, this process is slow. So at the end, you have average ratio E to E prime more than 15. And if you have this is supporting your diagnosis. Also, because pressure, high filling pressure of the left ventricle is transmitted retrogradely to the pulmonic circulation, to the right ventricle, you will see also tricuspid regurgitation. And this tricuspid velocity of regurg should be over 2.8 meters per second. That means that pulmonary artery pressure is higher than 35 millimeters mercury. So later, what do? You should check morphological criteria also. Here you can see enlarged left atrium, and the left atrium volume index should be over 34 milliliters per square meter. And if you see this function of the left ventricle, you can see good contraction add good thickening of the left ventricle. What about biomarkers? They should be elevated for, you have these values for if your heart is in a sinus rhythm, if heart is in atrial fibrillation. But if you don't have biomarkers positive, it doesn't mean that you don't have HFpEF, because it could be normal in some obese patients. So if you don't reach your point of 5 or more for the diagnosis, you proceed to advanced workup, that is for F1. And this is actually diastolic stress echo. Why diastolic? Because you are measuring during the stress echo diastolic parameters of filling of the left ventricle and movement of the mitral annulus, so this ratio, and also looking for increase in tricuspid velocity. Because that is very important, because some patients have only symptoms during exertion. So this is the protocol that you can use. It is supine bicycle. It is easier because you can follow these diastolic parameters from the ventricle. And here you can see that from the step, this ratio of E prime is heightened more than 50 millimeters. And also you can measure increase in tricuspid regurg velocity. Other parameters you can use. This Bay lines is very easy to use, and there are the signs of extravascular lung water. It is easy to see. Normally it is not present, but in the case of elevated pulmonary pressure, this number of B lines increase. And if they are above 5, 8, or 10, it is a sign of functional impairment, and it is a sign of poor outcome. What is happening with the right ventricle, because elevated pressure is transmitted to the right ventricle, and the right ventricle enlarge and change its geometry because of pressure overload. And you have increase in tricuspid regurg, and you have increase in fibrosis and stiffness. And you have also bulging the septal, that is, again, increase intercavitary pressure in the left ventricle. For the function of the right ventricle, you can easily assess measuring the movement, velocity of the movement of the tricuspid annulus, and it should be above 24, and not like in this our patient that is about 13 millimeters. This low TAPS and low function of the right ventricle and a large right ventricle are the signs of the poor outcome. You can see this from Obokata work, that if right ventricle is not preserved, this group of patients have poor outcome. Another sign you should measure, this is global longitudinal strain. This is measure of longitudinal shortening, because here you can see that this ventricle is quite normal, it's contracting, it's thickening, but the strain, measurement of strain give you possibility to see subtle changes in contraction when this what you cannot see with your bare eyes. So here at the bullseye, you can see that these segments of the base and the median part of the heart are not contracting properly. So the strain, this is the dark side of the strength and hypertrophic heart, because this longitudinal contraction is decreased. And what, after all this, if you are still without definitive diagnosis, so you should proceed to invasive hemodynamic measurement that you can measure at rest, left ventricle and diastolic pressure, pulmonary capillary wedge pressure. These are the numbers for HFpEF. If it is still normal and you have strong suspicions that your patient still have HFpEF, then you proceed to also diastolic stress echo in this invasive environment, and a pulmonary capillary wedge pressure should be more than 25. And for final etiology, you can use NMR, CT, PET scan, cardiac and non-cardiac biopsy, genetic testing, a specific laboratory testing if you have suspicious there is some strange accumulation in the wall of the heart. For the treatment, you should hear later in a few minutes from my colleague, but I should say only this, that the prevention is very important. Is very important consulting for against sedentary habit, against obesity, cigarette smoking, alcohol abuse. And you should insist to be best glucose control, because you see this relationship, how body mass index is related, and also glycemia is related to the risk of heart failure, hospitalization, very close and very high risk, even higher than risk for acute myocardial infarction. So at the end, I will say that management of heart failure with preserved ejection fraction is actually fine-tuning. And these are the questions that we should answer, and that is, should a diabetic patient with a heart failure be treated differently from a diabetic patient without heart failure for safety reasons? Should a heart failure patient with diabetes be treated with a specific anti-diabetic agent that provides a favorable heart failure outcome? And very important for all patients with heart failure with preserved ejection fraction, should heart failure with preserved ejection fraction without diabetes be treated with a specific anti-diabetic agent that provides a favorable heart failure outcome in the absence of diabetes? Thank you for your attention.
Thank you, Anna, for your excellent presentation. And thank you for the last questions, because I think the following two presentations will give you some of the answers for them. Now I will call Professor Giga to give us a cardiologist view on the efficacy on therapy of SGLT inhibitors in patients with heart failure. Professor Giga, please.
Thank you, dear colleagues, ladies and gentlemen. First of all, I would like to thank the organizer for inviting me for the second time to participate in the meeting. The topic of my today's lecture is what can we expect when we treat our patients with HFpEF with SGLT2 inhibitors. We are all aware that many drugs that show great improvement in patients with reduced ejection fraction failed to improve prognosis of our patients with HFpEF. But finally, unfortunately, we have two drugs that demonstrate a significant improvement in patients with heart failure and preserved ejection fraction. Those namely are dapagliflozin and empagliflozin in two large clinical trials, DELIVER and EMPEROR Preserved. However, when we have so strong data, it's always the question, how can we translate our knowledge from clinical trials in our everyday clinical practice? Both trials include huge number of patients, together more than 12,000 of patients with signs of heart failure and basically with mild symptoms, predominantly almost 3/4 of patients in New York Heart Class 2. For the inclusion in both trials, left ejection fraction should be more than 50%. Basically, we have to be aware and to emphasize that these are not patients exclusively with heart failure and preserved ejection fraction, but 1/3 of them was the patients with mildly reduced ejection fractions. And the third major component from the inclusion was the elevated level of NT above 300 picograms per milligram for patients in sinus rhythm. Basically, the inclusion criteria followed that algorithm, simplified algorithm from European Society of Cardiology, and is concordant with that algorithm, but with one exception. If we see, guidelines recommended the level of NT-proBNP for diagnosis of HFpEF is in sinus rhythm above 125 picogram per milliliter. In our trial, patients were included with much higher levels of NT-proBNP. Investigators basically wanted to increase the specificity, so to include the patients that really have heart failure, but the price that is paid for that is basically the lower sensitivity. Sensitivity of NT-proBNP around that cutoff value of 300 is something around 60%. It means that 40% with true HFpEF will be missed for the trial. And these patients are not so infrequent. Those are patients that have not so ominous prognosis and patients with elevated NT-proBNP level, but their prognosis is far from benign. And if we want to make a clinical profile of this patient, it could be the young, obese, hypertensive male patient with exertional dyspnea. Although the investigators wanted to increase the specificity in our trial, we have to admit that some of the patients without really heart failure may be included in both trials, since the slightly elevated NT-proBNP levels above or around 300 milliliters can be seen in patients with advanced stage with renal dysfunction, and we have to be aware that signs of heart failure have low specificity. Dyspnea as the major sign of heart failure have only specificity of 50%, and also echo parameters, left atrial enlargement and left ventricular hypertrophy have limited specificity. So although this number is small, some patients without true heart failure might be included in both of these trials. Irrespective of that, primary outcome of both trials show a very good reduction of 20% if combined endpoint of cardiovascular death and heart failure hospitalization. What is important for our patients, the effect starts very early after the initiation of therapy. Statistical significance in the LIVER trial between dapagliflozin and control group was obvious after 2 weeks of treatment. But we have to be honest and to see that in some subgroup of patients, the beneficial effects of SGLT2 inhibitors was attenuated. For example, in Emperor Preserved, there is attenuation of the effect in patients with LV ejection fraction above 60%, and for example, in trial with dapagliflozin, there is attenuation of the effect in patients with lower values of NT-proBNP below 600 picogram per milliliter. However, after the publication of both trials, their public data were published about the pre-specified meta-analysis of these two trials that demonstrated a significant reduction in primary endpoint in a large number of subgroups, but we have to admit that there is some attenuation of the effect in younger patients below 65 years of age. When we are analyzing the primary outcome of both trials, we have to be aware that the reduction in primary outcome was mainly driven by the reduction in heart failure hospitalization. There was much lower improvement regarding cardiovascular death that didn't reach statistical significance. There are several explanations for this fact. First, trials were not powered to detect a single component of that composite endpoint, but I think that here is the biology of heart failure, which preserves ejection fraction that matters and can explain lack of reduction in cardiovascular death. If we have a patient with heart failure and preserved ejection fraction. Those are very complex patients. More than 2/3 of them have 4 or more comorbidities, and there is a great chance to die because of these comorbidities and not of cardiovascular causes. Unlike patients with reduced ejection fraction, they die from cardiovascular disease in 80 to 85%. In heart failure with preserved ejection fraction, cardiovascular death is accounted only for half of all deaths. And if we see the data from EMPEROR and DELIVER trial, they're similar to data from other previous trials in similar population of patients with cardiovascular death contributing to total deaths of only 50%. So this is very small number, and it's very difficult to reach statistical significance in patients with HFpEF. Also, this is the explanation why there is no any improvement in overall mortality in both trials, because these patients have the equal chance to die from cardiovascular disease, as well as, for example, for infection, sepsis, terminal renal kidney disease, or malignancy. The other point which I would like to stress is the reduction in hospitalization for heart failure. That's the main effect of both drugs in these two trials. However, we should emphasize also that according to the data from EMPEROR Preserve trial, unfortunately, in main publication, there are no data in the DELIVER trial regarding total hospitalizations. There is no changes in number of total hospitalization. Basically, pretty low number of patients are hospitalized due to heart failure. Only 13% of all hospitalization was due to heart failure in EMPEROR Preserve trial, and it's something less than that are data from previous trials such as TOPCAT or iPreserved, but these trials were performed in more symptomatic patients. Almost half of patients were in New York Heart Class 2. So there is no significant change in total hospitalizations, and also it's very well known that in the last year of life, patients with HFpEF are mainly hospitalized for non-cardiac causes, irrespective of age and irrespective of gender. It's something that is very common in everyday clinical practice. For example, if we have two patients with pneumonia of the similar severity, one with heart failure and one without heart failure, we can expect that patients with heart failure will be more hospitalized due to some other conditions. So it is very hard to believe that the drugs that act on cardiovascular outcome can decrease all hospitalizations in patients that are such complex as patients with heart failure and preserved ejection fraction. The third major issue especially for our patients, is their quality of life. In DELIVER trial, there is a just slight improvement in Kansas questionnaire of 2.4. That's not a really clinically meaningful improvement, but I have to admit the data are not presented in the proper way. Much better way of presenting a quality of life is the way that data were presented in EMPEROR Preserve, that we see that there is less deterioration and more improvement in quality of life in patients treated with empagliflozin. But what was observed in EMPEROR Preserve trial is that there is no improvement in physical limitation. Maybe that seems a little bit surprising, but it's completely concordant with a previous publication. There are series of publications that didn't change distance during the 6-minute walk test in patients with heart failure and preserved ejection fraction. And similarly, is observed in a randomized trial, so-called Imperial Preserved trial, where patients with HFpEF were randomized to placebo and empagliflozin. There is only 4-meter increase in walking distance during the 6 minutes, which was not clinically and statistically significant. The only exception of these trials is preserved HF trial with dapagliflozin that show improvement in six-walk minute test of 20 meters that was statistically significant, but we have to be aware that this trial was conducted in more symptomatic patients, that 40% of patients were in New York Heart Class 3, so they were symptomatic, and for these patients that possibility to walk 20 meters more is really clinically important finding. And for the end, dear colleagues, let me conclude. Diagnosis of heart failure with preserved ejection fractions is still challenging even in clinical trials. With SGLT2 inhibitors, our patients with heart failure and preserved ejection fraction can expect early improvement in quality of life, but we have to discuss a little bit about improvement in physical limitation. They will be less hospitalized for heart failure, but these hospitalizations are relatively rare, but not less total hospitalization because of multiple comorbidities that require non-cardiovascular hospitalization. We observe some reduction in cardiovascular deaths, but no effect on overall mortality. These patients don't die exclusively of cardiovascular problems, and the idea to reduce overall mortality in HFpEF patient with any drug is too ambitious. And basically, we need to identify those patients who will benefit most from SGLT2 treatment in routine clinical practice. Thank you for your attention.
Thank you, Professor Giga, for a very comprehensive presentation, and especially on the very critical and clinical view on the benefits these drugs makes. Now, I will present an excellent endocrinologist who will give us the data about SGLT inhibitors in patients with type 2 diabetes. Marco, please.
Honorable Chairman, dear colleagues and friends, I'm most grateful to the organizers of the Eurasian Congress of Internal Medicine for granting me an opportunity to discuss with you today cardiovascular benefits of SGLT2 inhibitors in patients with diabetes. Diabetes is a large global scale problem with the number of estimated adult patients with diabetes reaching a staggering 700 million in the next 20 years. This is not only medical, but also a large social and economic burden, resulting in numerous microvascular and macrovascular complications, which need even a greater cost of treatment than the direct cost of treating diabetes. The cardiorenal risk in diabetes patients most frequently includes peripheral arterial disease, ischemic stroke, stable angina, heart failure, and myocardial infarction. But in fact, the first manifestations which affect close to 60% of diabetes patients are heart failure and chronic kidney disease, which overlap a lot. Overlap in their origins and risk factors, but also aggravate each other during the course of diabetes, leading to the same end organ damages and same end results. So it is a great demand to reduce the cardiovascular risk in diabetes patients, and this could be perhaps the most important focus of our treatment, and especially highlighting the importance of early intervention to prevent the irreversible damage and to act timely on this risk reduction. Diabetic cardiomyopathy is an entity which results from insulin resistance. metabolic injury with disturbed glycolipid metabolism in diabetes patient, leading to cardiac steatosis and myocardial fibrosis. There is a tendency to left ventricular remodeling, which is much more severe than expected from concomitant hypertension in these patients. With all these things in mind, we also evolve our concept of targets and goals in treating diabetes. Optimal glycemic control, of course, remains an important goal, but it's definitely not enough in contemporary treatment of diabetes. It is equally important to treat complications and comorbidities and also try to actively prevent chronic cardiovascular and renal complications from the beginning throughout the course of diabetes management. Having this in mind, we need to specifically select and think of antidiabetics drugs that could offer cardiovascular benefits. A modern concept of treating diabetes involves a certain paradigm shift with the patient-centered approach, relying on identifying individual risk factors, in particular hazards of heart failure, atherosclerotic cardiovascular disease. And from glycemic management, it proceeds to active blood pressure management, lipid management, and active selection of agents in treating diabetes which have proven cardiovascular and renal benefits. The risk for cardiorenal outcomes in diabetes patients starts even before we make the diagnosis. And at the time of the diagnosis, most of the patients have a high cardiovascular risk. We need to be aware of this and to think of prevention in the early course of the disease before the first cardiorenal events are discovered. Afterwards, we can think of a secondary prevention to try to avoid repeated cardiovascular events and try to delay or to revert the poor cardiovascular and renal outcomes from the beginning throughout the course of diabetes treatment. One of the ways that we try to do this is involving a relatively new class of antidiabetic, oral antidiabetic drugs with a completely novel mechanism of actions. These are SGLT2 inhibitors, which along with their anti-diabetic action have apparently multiple other protective effects, cardiorenal, antihypertensive, lipid-lowering effects. Their mechanism of action, which sets them apart from all the other oral antidiabetics, involves proximal renal tubule and selective inhibition of SGLT2, which leads to reduction in glucose and sodium reabsorption and increases glucose excretion through the kidney. This results in increased glycosuria, so having a positive urine finding for glucose is normal in these patients, but this increase in glucosuria leads to reduction in serum glycemia. This is in a nutshell their mechanism of action, but apparently their spectrum of actions is much wider than this. This is a family of medications which are all administered orally once daily. They have certain differences. Differences in half-life, in oral bioavailability, but importantly, they also have different confirmations from cardiovascular outcome trials. Some of them, such as empagliflozin, have confirmations from cardiovascular outcomes trials for reducing both major adverse cardiovascular events, heart failure, and chronic kidney disease incidence, while others, not to say that they are inferior, but still have maybe confirmations from large trials for some of these effects and not for the others. There is also another interesting quality that separates one from the other, which we will say a little bit more later, and this is specificity for SGLT2 as compared to SGLT1. In most drugs, we seek higher specificity, but we will see that in this context, maybe sometimes it is also desired and efficient to also target the SGLT1 receptors. What are the key benefits of SGLT2 inhibition? These could be divided in glucose-related and those not related to glucose metabolism. Through increased glycosuria, they reduce glycemia and reduce glycemic control parameters, improving them. This leads to improvement in glucotoxicity, even restoring beta cell function capacity, and they also result in body weight loss. Other than this, their effect on osmotic diuresis and natriuresis leads to reducing plasma fluid and interstitial fluid volume, reducing blood pressure, and improving glomerular filtration. All this in combination leads to multiple metabolic, cardiovascular, and renal benefits. In terms of specifically in terms of glycemic control, these are drugs with intermediate to high efficiency, but importantly, they act independently of insulin sensitivity or residual insulin secretion. So they could be administered either early in the course of diabetes treatment or later on, alone or together in combination with other oral antidiabetics or with insulin. So they act independently and jointly improve glycemic control. And what we can expect in practice is reduction in 1% of HbA1c. Their effects are durable, and this is also another important quality which sets them apart from the others. They do not cause hypoglycemias. So this is an advantage, for example, compared to sulfonylurea medications. They lead to an intermediate reduction in body mass. What is expected is 2 to 3 kilograms for 6 months of treatment, but which is sustained over several years. Both total fat mass is proven to be reduced, and also specifically visceral and subcutaneous fat, which is very, very important. And not only adipose tissue deposition is diminished, but also its inflammation, which is cause of many metabolic and cardiovascular problems. The main explanation is simple. It's caloric loss, because with this additional excretion of 60 to 80 grams of glucose per day, we lose some 300 kilocalories per day. But there are also other more subtle and very intriguing explanations. The SGLT2 inhibitors cause a change in substrate utilization, so a shift from glucose oxidation to increased lipolysis, fat oxidation, and ketone formation. They also act on appetite suppression. They also exhibit benefits on liver steatosis. The metabolic state, which is created with the use of SGLT2 inhibitors, is in many aspects fascinating, because this state imitating prolonged fasting is apparently quite tissue protective and energy preserving. And to some extent, it resembles the metabolic state of animals in hibernation. This is also one of the consequences is amelioration of low-grade inflammation, and some investigators also attribute anti-aging potential to these drugs. The cardiovascular benefits of the class of drugs, which vary somewhat from one product to another, are mostly judged as 11% decrease in major adverse cardiovascular events, which include cardiovascular death, myocardial infarction, and cerebrovascular infarction, but also a almost double a reduction in cardiovascular deaths or hospitalization due to heart failure. There is also some observed reduction in rhythm abnormalities and a claim of reduction in all-cause mortality. Interesting view is that these effects are much wider than what we could expect from the simple reduction in risk factors. such as improving glycemia, improving body weight, and so on. Also, they occur more rapidly, and they are also observed in patients without diabetes, and they are much wider than, for example, in other medications which are reducing glycemia more than SGLT2 inhibitors. So all this leads to thinking that there are many direct non-glycemic mechanisms of cardiovascular benefits. So aside of the direct effects, such as a reduction in plasma volume, tubuloglomerular feedback mechanisms, anti-inflammatory effects, ketone metabolism, and so on. There are apparently direct mechanisms on myocardium involving sodium involving sodium hydrogen pump inhibition, and with beneficial effects on cardiac remodeling and improvement also on endothelial function. With the alterations in metabolism which occur under SGLT2 inhibitors, there is a shift towards ketone bodies as a source of energy, which are sometimes described as a superfuel, providing improved myocardial efficiency and function, which is protective from energy depletion and prevents cardiac remodeling. Also, their effect on reducing fat also involves epicardial fat, which is known to be metabolically active and very deleterious on the underlying myocardium. There is increase in cardiomyocyte autophagy with the use of SGLT2 inhibitors and the reduction in stress-mediated apoptosis. They modulate endothelial function in sense of reducing inflammation and macrophage involvement and stabilization of atherosclerotic plaque. Not all of these findings occur from or come from clinical trials. Many of them are still result from preclinical animal models. But this is an avenue to point to new ways of possible application and also possible ways of investigating these products. One of these effects is reduction in arterial stiffness and vascular resistance, which results in reduction in cardiac workload. This is mostly attributed to inhibition of sodium hydrogen pump. These effects also apply on the vasculature of the kidney, with the vasoconstriction of afferent arterioles and reduction in albuminuria or slowing down of progression from micro to macro albuminuria. When blood pressure is concerned, these arguments and these data are more strongly clinically supported. There is a small but consistent reduction in both systolic and diastolic blood pressure, which remains sustained over several years. And most importantly, it is independent and quite complementary with other antihypertensive, such as medications acting on renin-angiotensin aldosterone system. Mostly this is attributed to increased sodium excretion, but also reduction in sympathetic nervous system tone. The reduction in plasma volume is importantly quite attributed to interstitial space more than the circulating volume, positively resulting also in edema reduction. So what is the place of the SGLT2 inhibitors in contemporary diabetes treatment? Many of the most recent guidelines place SGLT2 inhibitors as the first choice of add-on treatment after metformin, or even sometimes as a first drug of choice as a monotherapy drug, for example, in patients with high atherosclerotic cardiovascular disease risk, heart failure risk, and chronic kidney disease risk, in patients with target organ damage with multiple risk factors, specifically in patients which need weight loss or which are at least at risk for hypoglycemia, or if there was a metformin non-tolerance in these patients. They can be used at any stage, either at the beginning of treatment or later during the treatment of diabetes as a monotherapy or in combination with other oral drugs or with insulin. All of these mentioned effects of SGLT2 inhibitors open many new questions, such as their use in non-diabetic patients, which is still a field of intensive research, but there are proposals to use them outside of the context of diabetes in heart failure, chronic kidney disease, which is non-diabetic in origin, non-alcoholic fatty liver disease, or arterial hypertension. There are not numerous adverse events, but we should keep in mind that they could promote genital infections due to their mechanisms of increased glycosuria. This could possibly happen in 1 of 10 treated women or 1 in 20 men which are treated. And also a rare thing, but which we need to keep in mind, remembering their ketogenic effect, is that there is a theoretic risk of diabetic ketoacidosis. And very interestingly, this could be euglycemic diabetic ketoacidosis, which can sometimes be deceiving. Their effect on bone density is also sometimes questioned. Instead of conclusion, SGLT2 inhibitors appear to be critical for treating diabetes from perspective of cardiovascular disease. There is a reduction in cardiovascular outcomes, heart failure, renal failure, and apparently reduction in mortality. It is still challenging to implement all these new findings and guideline recommendations, but we must try to be open-minded to avoid clinical inertia, to just prescribe the old drugs, and to try to explore the full potential of SGLT2 inhibitors. Thank you all very much for your attention. And I now have a great pleasure and honor to announce our next speaker, expert endocrinologist Goran Cvijović, which is one of Serbia's leading authorities in diabetes and obesity. Will take this story further to GLP-1 receptor agonists and their effect on cardiovascular risk. Goran, please.
Thank you, Marko, very much for your kind introduction. Dear colleagues, the topic of my presentations are cardiovascular effects of GLP-1 receptor agonist therapy in patients with type 2 diabetes. Before I start, I would like to send you 22 Celsius degree warm greetings from Belgrade, hoping to see you in the following years in our very beautiful city. During this presentation, I will remind you just on the last ESC-ASD guidelines and what are the latest data on cardiovascular outcome studies with GLP-1 receptor agonist, and finally, what are possible mechanisms of action of these types of drugs. What do we know now is that in those patients who have established cardiovascular disease or at a very high cardiovascular risk, that means that they have multiple risk factors and or already have a target organ damage, we can introduce GLP-1 receptor agonist therapy immediately after metformin, or even we can start this therapy in drug-naive patients. The GLP-1 receptor agonists that are approved for these indications are liraglutide, semaglutide, or dulaglutide to reduce the risk for cardiovascular poor outcome. And only the liraglutide was the one that was shown to reduce the risk for cardiovascular death. This type of the anti-diabetic drugs are relatively new, but we already have so many proof to use them in our high-risk patients. This is a very nice meta-analysis where the major adverse cardiovascular events were evaluated. The MACE, basic MACE consists on cardiovascular mortality, stroke, and myocardial infarction. And you can see that almost all GLP-1 receptor agonists significantly reduce the MACE. The only one is the lixisenatide that did not show positive outcome. Here you can see very striking effects of liraglutide, semaglutide, both subcutaneously and orally administered, as well as dulaglutide and albiglutide. I will start the data very subjectively with the leader or liraglutide study, because I was lucky to be participant in this study. And this is the study that show us significant reduction in MACE, and it is mostly due to the reduction in cardiovascular death. This GLP-1 receptor agonist is the only one that is administered once daily, in comparison to the other that are administered once weekly, and that might be one of the reasons why we have maybe slightly different results. Probably pharmacodynamic is one of the key elements. Also, I want to show you that in comparison to the SGLT inhibitors, where you saw the positive outcome very short after introducing the therapy, here after 8 to 12 months, you can see the positive results. The important thing is that these positive results were not only for the basic MACE. When we analyzed further data, we showed that these positive results is also if we taking in consideration the coronary revascularization or hospitalizations for unstable angina or heart failure. This is the SUSTAIN-6 study, the study with subcutaneous semaglutide. And here you can see even more striking effect on the MACE, but it is primarily due to the reduction in the non-fatal stroke. There was no change, there was no difference in reduction of cardiovascular death or non-fatal myocardial infarction. The very important data are that you can prevent the stroke in all types of the strokes, so ischemic and hemorrhagic. And the most striking effect is on the stroke for the small vessels. And probably this is the reason why we have such reduction in the non-fatal stroke. These effects are, these data are so convincing that already some national associations suggested the semaglutide as a secondary prevention therapy for patients who had stroke. And one of the reasons for that is that this positive effect was observed even in those patients who previously had stroke or myocardial infarction. And this effect is independent of the age, sex, hypertension, and all the other parameters that we can follow in this type of the patients. If we analyze further data, we saw that in a liraglutide study, these positive outcomes are observed as a MACE or expanded MACE or only cardiovascular death, independent of the duration of diabetes and independent of the kidney function. The same type of the results were observed in SUSTAIN-6 or a semaglutide study, where we also saw the positive outcome independent of the diabetes duration or kidney function. There is a tendency that there is reducing the cardiovascular death in those if we introduce therapy early in the course of diabetes, actually almost immediately after the diagnosis, but we wait for further evaluation and further data. One of the elements that can reduce our positive outcome are microvascular complications. And here we can see that if the patient has more microvascular diabetic complications, the positive outcome will be less. It is especially observed in studies with semaglutide, and there was also some results showing that even in this type of patients starting with semaglutide can deteriorate diabetic retinopathy due to very quick reduction in HbA1c, very fast reduction in HbA1c. Dulaglutide is also once weekly administered GLP-1 receptor agonist, and we have the similar pattern of the cardiovascular outcome as it is with semaglutide. It's copy-paste effect. Here you can see significant reduction in cardiovascular outcome and significant reduction in non-fatal stroke. And also the important data is that these positive results were obtained independent of the age, sex, duration of diabetes, history of cardiovascular disease, baseline HbA1c, or body mass index. And finally, there is elbiglutide that is also once weekly GLP-1 receptor agonist, showing a significant reduction in MACE, and in this case, significant reduction in non-fatal myocardial infarction, while there was no difference in reduction of cardiovascular death or non-fatal stroke. This type of pattern in reduction in HbA1c, in body weight, in systolic blood pressure, you can see in every study with GLP receptor agonists. I can only say that the most intensive reduction is observed in the semaglutide study. The semaglutide has highest potency to reduce HbA1c and body weight in comparison to the other GLP-1 receptor agonists. But if we analyze all the data, we can observe that reduction in HbA1c, reduction in body weight, reduction in systolic blood pressure cannot be final explanation why do we have so good outcome results. And there must be something else. This is something very new. This is tirzepatide, a dual GIP and GLP-1 receptor agonist. And he showed the greatest potential to reduce HbA1c. You can see up to minus 2.5% of HbA1c, and the highest potential to reduce body weight. You can see the dosage of 15 milligrams up to 11, average body weight reduction was 11 kilograms. And also you can see that there is a significant improvement in these parameters in comparison to the semaglutide, which was the most potent GLP-1 receptor agonist. But when we observed cardiovascular outcomes, there was improvement, but any of it did not reach statistical significance. Is it a composite MACE-3 or MACE-4 or any of the elements of the MACE? There was no significant reduction. One of the one of the points that might say that we will see different result in the future is because this data were analyzed after 1 year therapy, and we saw in the previous study that that was approximately the time period when the difference, when the curves start to dissociate in a positive manner. So what are the other mechanisms of action of GLP-1 receptor agonists that can help us to explain such a good outcome results? We know that GLP-1 receptor improved the pancreas function in improving the insulin biosynthesis secretion, reducing glucagon secretion, and improving glycoregulation. It reduced the levels of postprandial lipids. It reduced chronic inflammation. It reduced body weight, especially acting on the level of the hypothalamus. It reduced the blood pressure, systolic blood pressure. It improved kidney function, and it seems that it has direct cardioprotective effects on the heart. So I will try to show some of them. These are the direct effects of GLP-1 receptor agonists on the blood vessels, on the arteries, and the two most important are improvement in endothelial function and reduction of vascular inflammation. There is also, in some level, less lipid accumulation and less stimulation of the activation of the small muscles and their proliferation. So independent of the blood pressure, weight, and HbA1c, we have direct effect on the blood vessels. This is in a study in animals showing us that administration of the liraglutide significantly reduce atherogenic plaque on the aorta. And it was shown only for the liraglutide. It's direct effect, the liraglutide on the arteries. If we evaluate endothelial function in the patients with type 2 diabetes, this is a nice study comparing GLP-1 receptor agonists and SGLT2 inhibitors, showing us that they have a significant effect in improving endothelial function, and at the level of the peripheral arteries, we have almost the same intensity, same effect, but at the level of the heart, GLP-1 receptor agonist has much significant effect, especially as, for example, this index, myocardial global work index. Finally, it was shown that administration of the GLP-1 receptor agonist at the moment of ischemia, at the moment of STEMI, will significantly reduce the final infarct mass. I must here give you a point. This administration, these are not patients who were previously treated with GLP-1 receptor agonist. This is administration of the liraglutide at the moment of ischemia. So we probably could have a better even effect in those patients who were treated with GLP-1 receptor agonist. The same results were obtained with another GLP-1 receptor agonist. It is exenatide, but it is important to say that this effect was observed only if the exenatide was administered in the first 2 hours of the ischemia. So this is one of the latest meta-analysis showing us direct effect of GLP-1 receptor agonist on the heart. And here you can see that they significantly improve systolic function, they reduce diastolic dysfunction. And for those patients who had myocardial infarction, GLP-1 receptor agonists reduce infarct size. Only the liraglutide demonstrated improved systolic function by increasing the ejection fraction and reducing the left ventricular and systolic volume. I must mention that all these results, all these effects, you can observe with patients with preserved ejection fraction. In those patients who have significant reduction in ejection fraction, this is not the case. So what we can see, we have beside the effect we saw on the HbA1c, body mass index, and the systolic blood pressure, GLP-1 had direct effect on the heart, increasing glucose uptake in myocardium, improving left ventricle function, reducing ischemic injury and chronic inflammation. And on the level of the arteries, it improves vasodilatation, it improves plaque stability, improves blood flow, endothelial function, reducing inflammation, platelet aggregation. If we compare the two types of drugs we mentioned in the during this symposium, we saw that they are both very show high efficacy in reducing HbA1c and body weight and systolic blood pressure, but the mechanism of action are completely different. SGLT2 inhibitors are predominantly dynamic, distressing the nephrons and reducing cardiac stress, while GLP receptor agonists reduce chronic inflammation, improve endothelial function, and reduce ischemia reperfusion injury. So if you have a patient with heart failure, your type of the drug should be SGLT2 inhibitors. If you have a patient with advanced atherogenic disease, you should introduce him GLP-1 receptor agonist. Thank you for your attention. So we finished our presentation on time, and I see on the chat that we have some questions, and I will ask my colleagues to give us the answers. So as I saw, one of the first question should be just a second. Which lab marker is the most specific in diagnosis of heart failure? And is there anyone that is good as it is BMP? I will ask Professor Giga if he can answer, because I saw.
Yeah, by mistake, I typed the answer also already. First, I want to congratulate all colleagues for the brilliant presentations. And now we have to discuss these questions. First, is which lab marker is most specific in diagnosis of heart failure? Basically, in everyday clinical practice, NT-proBNP is the most specific marker. There is always that trade-off between sensitivity and specificity. With increases a cutoff value, you can increase specificity. For example, that level of 450 picograms per milliliter has very good specificity of 87%, but there is a lower sensitivity. But I think that the key message is that we can stick to that, not only to use that simplified algorithm, but to use really clinical judgment. Even in patients with low NT-proBNP levels, we can suspect, if we have a clinical grounds to suspect on heart failure, we can and we should perform the whole spectrum of diagnostic potentials, including diastolic stress test and even invasive pressure measurements.
Thank you, Professor Giga. Now I will ask Marco, are there any data about SGLT2 inhibitors in patients with chronic cardiac heart failure and type 1 diabetes?
I would also like to compliment on all the speakers and to thank all the participants for listening. The application of SGLT2 inhibitors in type 1 is still a little bit controversial in our clinical practice, mostly due to the fear of diabetic ketoacidosis, which is more prominent in type 1 than type 2 diabetes. But there are clinical studies which point to apparent safety in applying dapagliflozin in type 1 diabetes, but from clinical trials to everyday practice is a long way. But this issue becomes less controversial. This was not application in particularly heart failure patients, but generally the testing the efficacy for glucose control in patients with type 1 diabetes. Yeah, so it is still something that we mostly avoid in clinical practice, but it's if larger trials demonstrate efficacy and safety, this could be also a future for maybe additional therapy, and in particular in the aging population of type 1 patients, because type 1 diabetes is a disease of pediatric age and young adult age, but with prolonged and improved survival and outcome, we now see older and even geriatric patients with type 1 diabetes.
Okay. There is a question about should heart failure patient with cachexia or sarcopenia be described GLP-1 receptor agonist? Absolutely no, because they will further reduce body weight, and the GLP-1 receptor agonists are not the drug of choice for patients with heart failure. It's therefore with advanced atherosclerosis. Marco, what kind of lab test you use when you want to introduce SGLT inhibitors?
Well, the efficacy of treatment is followed as with other anti-diabetics, so with glucose profiles, with retrospective marker of glucose control, which is HbA1c. We need to be cautious of the obvious thing that there is increased glycosuria, so we should not be alarmed with this. This is something which is expected and normal. This is concerning introduction of treatment. We also need to assess renal function, but this threshold below which we should avoid SGLT2 inhibitors is being moved downwards. So basically, currently, any estimated GFR over 30, we can safely introduce SGLT2 inhibitors. Regarding the other effects, this is during the follow-up, we check up on their blood pressure effects. We send them to our colleagues cardiologists for checkups with echocardiography and so on. We check perimeters of hepatic function improvement, morphological and laboratory and so on.
How confident you are if you introduce the patient SGLT inhibitors and he is not a diabetic patient? Do you often prescribe them to the non-diabetics or not?
I personally still do not prescribe them to non-diabetics. I hope that this is something, the avenue which is going to show more promise in the future, but I mostly prescribe them to diabetic patients only.
Okay. Professor Dikic, and you? Anna, please, microphone.
Sorry. Yes, sometimes I prescribe this SGLT for my heart failure patient, because when everything I tried, then I seek for another medication. So I think some of them have the good results for the heart failure. And what I want to say here, because I was talking about heart failure with preserved ejection fraction, and mainly SGLT2 inhibitors goes for the glucosuria. I have to mention that this heart failure patient with preserved ejection fraction, they depend on the equilibrium of the volume. So everyone should be careful about excessive use of diuretics and the drugs that can reduce totally volume, because their filling of the ventricle is depending of the circulating volume of the blood. So this is fine-tuning that I said, that you have always to check some by echocardiography, by natriuretic PET is what is going on.
Thank you. Well, dear colleagues, I think we can close this session because I do not see any further questions. All the speakers will be open for any other question if you need, and we'll be very happy to answer you. Thank you very much for attention. Goodbye.
Thank you.
Thank you all. Thank you. Bye-bye.
Dear colleagues, thank you.
Thank you.
We ended our symposium. I'll back next week with further information. Now we should finalize our Congress. There is the third day, the final day. We will end, and I'll go back next week.
Okay.
Thank you
Thank
very
you
much,
very
and
much.
good luck.
Bye.
Thank you.
Bye.